This module is on laryngectomy, everything you need to know to care for this special population, presented by speech-language pathologists Kayla Terry and Caitlin Harvey at St. Luke's Hospital. Learning objectives for this module are definition of laryngectomy, respiratory considerations, difference between laryngectomy and tracheostomy, safety considerations, care and maintenance of laryngectomy stoma, methods of communication, dysphagia post-laryngectomy, and how to identify a laryngectomy patient versus a tracheostomy patient.
What is a total laryngectomy? A total laryngectomy procedure involves removal of the larynx or the voice box. This includes the vocal folds. After a laryngectomy, the trachea is redirected to the front of the neck above the sternal notch, creating a permanent stoma or hole for the patient to breathe through. The esophagus is then rebuilt. Following a laryngectomy procedure, the anatomy is altered. The nose and the mouth are no longer connected to the lungs, and the patient is permanently breathing from the stoma or the hole in their neck. The esophagus or the food pipe is still connected to the nose and the mouth. After a laryngectomy procedure, important functions of the nose are lost. No air moves in or out of the nose, and air is no longer heated or moisturized as it enters the nose and travels to the lungs. This is why HMEs or heat and moisture exchangers are very important. The upper airway is no longer connected to the lungs, and the sense of taste and smell may be reduced. There have been approximately 100,000 laryngectomies performed worldwide since 1873. About 4,000 to 5,000 are performed in the US each year, and there's approximately 10,000 laryngectomies currently living in the United States.
Now we will move on to the important functions of the nose and upper airway. The nose heats and moisturizes the air before it enters the lung, increasing air temperature to around 29 degrees Celsius and humidity to 70%. The nose also filters impurities such as large particles and provides resistance, which is important for maximum air intake and the health of the cilia in the lungs. Your nose also provides a sense of smell and helps with taste. What does the heat and moisture exchanger do? It replaces the important functions of the nose and heats and moisturizes the air before it enters the lung, just as the nose does, increasing air temperature to the same 29 to 30 degrees Celsius as the nose does, and also increases the relative humidity to 70%, exactly as the nose does. It also provides the resistance to air as it passes through the HME, just like the nose. It does keep larger particles out of the lungs, such as insects, crumbs from eating, grass, large pollen, things like that. However, an HME does not filter microscopic particles such as bacteria and viruses. There is only one HME that does this, which will be important for patients to have on hand as needed. How does an HME work? The sponge in the center of the HME is covered with a sodium chloride solution that provides the heat and moisture. How do you get HMEs? In the hospital, Central Supply keeps them in stock and can be ordered via General Supplies in Epic. Otherwise, a patient requires a prescription that will be provided by the speech pathologist. HMEs require special maintenance and care. How often does the HME need to be changed? Every 24 hours or more often if soiled with mucus. If soiled, can it be rinsed with water? No, absolutely not. HMEs cannot be rinsed. It will rinse off the sodium chloride solution and then it can grow bacteria. If you are not sure how old the HME is or how long a patient has been wearing it, discard and place a new HME. You can also replace the HME if heavily soiled with mucus. How often should an HME be worn? 24/7, no exceptions. This helps with mucus and secretion management. Can a breathing treatment be given with the HME on? No, it cannot. The medication will ruin the HME. Remove HMEs for any medicated breathing treatments and replace once breathing treatment is complete. Can supplemental oxygen be provided with an HME in place? Yes, supplemental oxygen can be provided via trach collar setup. However, all supplemental oxygen being provided must be dry when an HME is in place. Otherwise, the patient will get too much moisture, and that is not good for the airway. Every laryngectomy patient gets what's called a pulmonary kit. This kit is kind of their starter pack to provide them with all the supplies they will need right after surgery. Every patient and family also gets this folder with a lot of good information about products, what a laryngectomy is, care tips, etc. In the pulmonary kit, there are some sheets, HME change log that can be used. Some things to hang up in the room. That patient is a neck breather. There's 2 of those. And then a writing board. There's a couple different writing boards in the kit that they will receive. Patients will also get 2 boxes of HMEs. Come in packs like this and can be popped out for use. They will get a box of neck bands. They're white, and they fit similarly to like the Dale collars for a trach tube. They will also get what's called a shower aid. This fits on the Larry tube so water doesn't get in when they are cleared to shower. They will receive an electrolarynx, and some tube brushes. These are used for cleaning their Larry tube.
Since the vocal cords are removed following a laryngectomy, the patient will no longer be able to verbalize via organic speech. There's a few methods of communication post-laryngectomy. The 3 most common options are a voice prosthesis, an electrolarynx, or esophageal speech. Esophageal speech is the least common, and it is a technique that requires talking while belching. This can be difficult to learn, and not many laryngectomies use this as a method of communication. The 2 most common methods of communication is the voice prosthesis or the electrolarynx. The voice prosthesis is a small silicone device that's inserted via incision between the walls of the trachea and the esophagus. The electrolarynx is a handheld device that is put against the cheek wall or under the chin and vibrates to produce sound. This can also be used with a straw attachment that is placed in the mouth. This is the electrolarynx. It's the handheld device that can be put against the cheek wall or under the chin, and it vibrates to produce sound. Some patients might need to use the straw attachment, especially if directly after surgery. That attaches onto the electrolarynx like this, and then the straw is inserted into the mouth. This is the voice prosthesis. This will be inserted via incision between the walls of the trachea and the esophagus. You will be able to visualize this in the patient's trachea once the laryngectomy tube is removed. For the voice prosthesis, as you see pictured, it is inserted in between the trachea and the esophagus. Once the Larry tube is taken out of the stoma, you will be able to visualize the voice prosthesis. If this appears dislodged, page the ENT group as soon as possible and consult the SLP.
Okay.
Let's go. What do you need from me, ladies?
Dysphagia after laryngectomy. Laryngectomy patients cannot aspirate while eating and drinking unless there is a voice prosthesis in place. How do I know if the voice prosthesis is leaking? If you see food or liquid is the most common, coming through the voice prosthesis or around the voice prosthesis, it is leaking and this will lead to aspiration. If you notice that the voice prosthesis is leaking, make the patient NPO and consult the SLP as soon as possible. Also page the ENT team. Laryngectomy patients often have esophageal strictures that make swallowing difficult. Showering and shaving post-laryngectomy. The stoma must be protected at all times while showering or shaving in order to prevent aspiration. Shower aid must be used when showering or shaving. The shower aid will fit onto a Lary tube, Lary button, or base plate. Central Supply keeps these in stock and they can be ordered via General Supplies in Epic as needed.
Tracheostomy versus laryngectomy.
What is a tracheostomy? A tracheostomy is a tube inserted through a small incision in the windpipe to relieve respiratory distress. The nose and the mouth are still connected to the lungs, but oxygen primarily moves in and out of the trach tube. The tracheostomy is one of the most frequent procedures performed in an ICU, and on average, 100,000 tracheostomies are performed each year in the United States. There are some differences in the anatomy between a tracheostomy patient and a laryngectomy patient. For a trach patient, air primarily moves in and out of the trach tube. However, the nose and the mouth are still connected to the lungs, and air can be breathed in and out of the nose and the mouth. For a laryngectomy patient, no air moves in and out of the nose or the mouth. Air only moves in and out of the new stoma that is created in the neck. Tracheostomy tubes and laryngectomy tubes look different. A trach tube looks like this. Trachs can have a cuff or no cuff. Lary tubes look like this. There are also Lary buttons. These are a little less common. However, this is what they look like, and some patients do wear these. It is noted that popular trach tube brands like Shiley and Jackson also make Lary tubes, which can be easily mistaken for a trach tube. This is why it's always important to ask your patients what their history is. There are also some ventilation differences for tracheostomy patients and laryngectomy patients. A trach tube is compatible with the vent circuit. It is also compatible with an ambu bag. You can inflate the cuff to form a seal for mechanical ventilation, and the patient can be intubated orally or nasally if needed. For a laryngectomy patient, you cannot deliver oxygen to the nose or the mouth. It will only go into the stomach at that point. The oxygen must be delivered via the stoma in the neck, usually via a trach collar attachment. If a patient needs mechanical ventilation, a cuffed trach tube or endotracheal tube must be inserted into the stoma. A pediatric mask must be used over the stoma if providing oxygen via an ambu bag. All laryngectomy patients should have an emergency airway cart in their room that is specific to laryngectomy patients. If there is not one in the room, please contact respiratory therapy.
Safety concerns. A laryngectomy is often mistaken for a tracheostomy. Example, a laryngectomy patient may have a tracheostomy tube for ventilation or airway stabilization. The airway would still need to be managed following all laryngectomy precautions, not tracheostomy precautions. Following a primary or initial laryngectomy surgery, a trach tube will likely be placed for the first 3 days. Following these 3 days, the trach tube will be exchanged for a Lary tube. It is pertinent that the airway is continued to be treated as a laryngectomy and not a tracheostomy. Anatomy of the airway is different. A patient with the trach's upper airway and lower airways are still connected. Airway management is different. Supplemental oxygen cannot be delivered via mouth or nose for a laryngectomy patient. Breathing treatments must be delivered via stoma for laryngectomy patients. and the Larry tube can be completely removed from stoma for daily cleaning and maintenance. A code does not need to be activated if the Larry tube becomes dislodged. Simply replace Larry tube. Go ahead and place the Larry tube in the stoma. It might make them cough a little bit. To remove the Larry tube, just slowly dislodge from the stoma. Passy-Muir valve, or PMV. What is it? It's a speaking valve that helps restore a natural breathing pattern. It's either purple or aqua. The use of the Passy-Muir valve strengthens the lungs by providing resistance when breathing, and it can also improve swallow function and safety. How does it work? It turns the trach into a one-way valve. It allows air in but not back out, and it redirects the air through the upper airway for speech. Safety considerations with a PMV. Use only on a trach patient. Never put a PMV on a trach tube that may be in the stoma of the laryngectomy patient. Always deflate a trach cuff before placing on trach. Never allow the patient to sleep with the PMV in place. Remove the PMV immediately if the patient shows signs of distress or if there are changes in vital signs. Ventilation with the Passy-Muir valve. Air still enters through a trach via PMV. Air is then redirected into the upper airway. Nasal cannula can be placed if needed, but it is not as effective as a trach collar oxygen because inhalation still occurs via trach. Remove PMV prior to bagging for maximum efficiency. Remove PMV prior to inflating cuff if patient requires mechanical ventilation. The PMV can be placed in line with the vent, but the cuff must be deflated, therefore cuff leak may alarm on the ventilator. Only the aqua valve can be used for an inline vent. Trach capping. What is it? A cap is placed on a trach tube when physicians are attempting to wean a patient from a trach in order to decannulate or remove the tracheostomy tube. These caps can vary in color from red to white. The patient is able to speak with the trach cap in place. Ventilation considerations. The patient breathes through the nose or the mouth only. All supplemental oxygen must be administered via nose or mouth. And the cap must be removed and cuff inflated if the patient needs to be placed on mechanical ventilation.
What do we need to be aware of as patient care providers? There is an increase in the number of laryngectomy patients being admitted at St. Luke's. Of these, many are undergoing their laryngectomy surgery here at St. Luke's. Others are post-laryngectomy and being admitted for either complications related to a laryngectomy or other medical comorbidities. It is important to be aware of the patient's history so you know how to treat their needs. How do I know the difference between a trach patient and a laryngectomy patient? Always ask. Ask the patient and or family member, ask the facility they came from, or anyone else that is involved in the patient care. Listen to what they have to say. Give the patient time to communicate, as many laryngectomy patients are unable to communicate verbally. Provide pen and paper if needed. Read prior H&P and other notes if available. Look for signs. There should be a laryngectomy sign on the patient's door. The patient should also have a neck breather bracelet. There may be an electrolarynx present. There may also be an HME in place. You may also see a voice prosthesis in the stoma or laryngectomy supplies present at the bedside. They may also have a wallet card explaining their neck breather status. These are all red flags that this patient is a laryngectomy and not a tracheostomy. It is safe to say that the laryngectomy population falls under the category of very low frequency but very high risk. We have to be careful. This sign is what you may find on the door for a laryngectomy patient or hanging above their bed. If you know that a patient has had a laryngectomy and they do not have this sign on their door or above their bed, please call the speech department or the ENT department or respiratory. Any of us can get this sign for you. Discharge considerations. What do we need to know? The speech pathology has a role, and so does a social worker and case manager. The speech pathologist will obtain the stoma management supplies. They will assist patient and family with filling out necessary forms. They will fill out a prescription form and submit it to the physician for signature, and will send all necessary paperwork to the laryngectomy supply company. The social worker and case managers will obtain all other supplies and equipment associated with laryngectomy care and set up any post-acute needs. For questions or further information, please contact the Respiratory Care Department or the Speech Pathology Department. We are always happy to help.